I'm John Strum, and this is RealTalk MS. It's June 4th, and we have a lot to talk about. Last week, thousands of clinicians, nurses, physician's assistants, rehabilitation specialists, and others traveled to Nashville to attend the Consortium of Multiple Sclerosis Center's 38th annual meeting. Welcome to part one of my coverage from that meeting. As much as I enjoy producing this podcast from the studio, I love getting to meetings like this because they give me an opportunity to connect face-to-face with some of the experts who are changing the multiple sclerosis treatment and research landscape. During the meeting, I had an opportunity to set up my microphones at the National MS Society's booth in the conference exhibit hall, where I had conversations with two people who I consider to be difference makers when it comes to improving MS care. First, I met with Dr. Kathy Zackowski, the Associate Vice President for Research at the National MS Society. Dr. Zackowski has been kind enough to join me at this conference for the past several years, sharing some of the presentations that caught her attention. I'm at the Consortium of MS Center's annual meeting, and I'm here with Dr. Kathy Zackowski, the Associate Vice President for Research at the National MS Society. And Dr. Zackowski is here to kind of give us a download on some of the things that she has seen, some of the presentations she's been sitting in on during the meeting. Welcome, Dr. Zackowski.
Hi, thanks for having me.
Absolutely. It would not be a CMSC meeting if I didn't have you. You've always been so gracious to donate your time and spend a few minutes talking to us.
Thank you. I do really enjoy this meeting. It's so diverse.
It is. And to that point, before we get into the things you've actually seen that you want to share with us, maybe you could help my listeners understand why so many healthcare professionals from a variety of fields, everything from neurologists to nurse practitioners to MS nurses to rehabilitation specialists, they're all here. Why do they come?
Yeah, it's a really unique meeting because it is focused on multidisciplinary care, which means it's not just about your medical care, it's about your whole life and how you live with MS. And that it turns out that you need more than just a medical guide or a physician. You really need, there are experts trained in understanding your physical health and experts trained in understanding your emotional health and can help you with specific symptoms that your physician might not be as well trained in. And so there are speech therapists here, physical therapists, occupational therapists, psychologists. Even there's a whole new section of dietitians that are here. And with this understanding that we don't know the right diet, but we need to be studying that, and people want to know what they should be eating. And so there are probably there's some information we can share, but this meeting allows people to come together and network and learn from one another. And also, I am hoping gather an appreciation for the importance of this multidisciplinary care idea.
Well, I hope that at least clarifies a little bit why we have so many people from so many different roads in the MS treatment community all coming together. And now that we're here, tell us, what have you seen that it's really caught your eye?
There are a couple of things I wanted to share. One, the first thing I went to was put on by the Foundation for the Consortium of MS Centers. It was sponsored by them, and it's called the MS Mentorship Forum. And it was essentially a room of about 100 young clinicians who are in their final stages of training. I was asked to be part of a panel of individuals to describe how and why we're focused on MS in our work, and it was inspiring to hear from physicians in private practice, various people who work at various academic centers around the country. The industry was represented, and all sharing ideas on how to get started in this field of MS and why it has been fulfilling to them. And one unique thing we did this year is they broke out into groups. So they said, We're going to have 10 different interest groups. You decide, you, the trainees, decide which group sounds interesting to you. So I went to an allied health group, which was made up of PTs, OTs, psychologists, dietitians. There was even a palliative care physician there, with really just trying to get at how do we treat symptoms of MS better than we do now, and how do we stay energized and engaged in that as we move through our career. So it was just a really nice opportunity to meet kind of the young up and coming providers that are coming through the system, and to offer, and the fact that they'd be interested in hearing our feedback was really great.
I think that's terrific. I mean, first, we don't have enough providers coming into the field yet. And it's wonderful that you get a whole room full of them who want to learn how to do it better, even when they're just starting out.
Right, exactly. They're open-minded, and they recognize that we can't, there's really no one provider that has it all, right? We have to work together.
Exactly. So what else did you see?
All right, so it started really with the Kurtzky Memorial Lecture, which is a huge lecture room, and one person is asked to talk, and this year it was Dr. Darren Okuda. He's from the University of Texas Southwestern Medical Center, and he's a researcher, not a clinician, and he's focused on searching out visual limitations and their effect on the interpretation of MRI data, which I know sounds a little out there, but he presented some really interesting slides where he described how our eyes deceive us and even provide false information at times without our awareness. And he showed evidence that our visual interpretation of MRI changes over time are not always accurate. And that's disturbing, right? Because so many people with MS really rely on that and get that information from their physician and get worried when it looks like lesions are expanding or there are more lesions. So he showed examples that we could try in the audience that showed how we see that what we see is a reflection of our environment. So it's the amount of light, the use of color that really impacts what we see. And he described the value of MRI conformational measures that are focused on three-dimensional shape, structure, and surface characteristics that offer objective ways to interpret MRI in people with MS. This information has the potential to improve the accuracy that a radiologist would be able to read an MRI and relay this to people with MS. It could improve how we study MS and how we educate people about MS. And his examples were really, really shocking in that he showed that even when it looks like a lesion might be slowly expanding over years, using these new techniques, he could show that some of them are actually shrinking. And using this quantitative method, that would be really lovely news to get versus the fact that your lesion might be getting bigger over time. So I thought it was very inspiring, and I think it's really nice to know that I guess quantitative scientists are really at work trying to understand this and make this MRI tool even better than it is now.
The idea that your neurologist could say to you, that lesion that we identified before, it's actually getting smaller. We don't often get news like that,
no,
right?
Exactly, right. I bet that's very rare. So that would be lovely to get.
So, you have something else you could share with us?
I do. The other thing I wanted to share is that something I do with the society. So we have a group that is called the Wellness Research Working Group. This group has been active since about 2015. And let me explain why the society would be even interested in a group like this. So we know that wellness is a high priority for people living with MS. People often will say, what can I do today to feel my best? They'll ask their providers, will lifestyle interventions even impact my symptoms? Will they alter the disease course? And these are all questions we don't have answers to. So we got together in 2015 and we defined wellness as an active process through which people become aware of and make choices toward a more successful existence. And we acknowledge that wellness includes a large number of modalities or areas, including cognition and diet and emotional well-being and spirituality and relationships and work and home life. I mean, all of that really is what encompasses our well-being or our wellness. So they created this wellness research working group to allow for an opportunity for scientists to come together and bridge this gap between what are the questions and what are the answers. And so the group is made up of about 35 people with background in psychology, exercise physiology, neurologists are there, internal medicine experts, dietitians. We have some people that are behavior change experts. Occupational therapy is represented. So it's a variety of people, and we divide it into smaller groups. So we have a physical wellness group and a nutrition and diet wellness group and a psychosocial wellness group. And each of these groups provides a platform to discuss research, to network, and also to inform the society about the newest ideas and opportunities in the field of wellness research. And I thought maybe I'd share just a couple things we've done over the years. So, we've published a paper with exercise guidelines for people with varying abilities. We published a paper called Lessons Learned from Diet Studies in MS that is meant to be informative to diet researchers. And then we took that information and we updated the website for the society, clarifying which diet studies are out there and providing kind of a plain language description of why that study might be important. We give presentations at conferences and provide content for the society's Pathways to Wellness programs, which have been really informative for people with MS. But the group met here to establish new goals for the coming year and discuss new ideas for how to obtain data to support what lifestyle choices are best, which ones can impact the biology of MS, which ones can affect common comorbidities that people with MS have. So the hope is that this group could provide some guidance to the MS community around all of those types of issues over time.
Something I talk about on this podcast fairly regularly is while someone who's living with MS may be waiting around for the next pharmaceutical miracle to come down the pike, there are so many things people can do for themselves in terms of the lifestyle choices they make. And all of it seems to be part of exactly what this initiative is about, whether it's diet, exercise, so many things, sleep, all of it. And it's great to hear that this group is not only exploring, but even defining the science of wellness. Makes a huge difference. It's a word that unfortunately marketers love to use. And right now you could probably drop into your favorite store and pick up a bar that's being promoted as contributing to your wellness. And what it's contributing to is a ridiculous number of calories. And so having evidence-based kinds of strategies and tips to share, I think that makes a huge difference.
Yeah, I'm happy to hear you say that. I really think it's an important area that needs more research. We need to try to get to the bottom of what are the guidelines that really make a difference so that we don't just try to not eat or exercise all the time. There's probably the right dose for all of these things that we need to understand.
You're probably right. And I'm wondering, have you seen anything else you can share?
So one last thing I wanted to share was I went to a cognitive rehabilitation session. This was put on by doctors Erica Weber, Ralph Benedict, Brian Sandroff, and John DeLuca. So they're all up in the Northeast. And I wanted to share a couple things that I learned there. So it was really encouraged that people should be referred to get cognitive rehabilitation, and that when clinicians are evaluating for this, they need to keep in mind not only the MS, but also the person's age, the type of disease course they have, even what their personality traits are, because it turns out all of those things will affect our cognition. They also described the importance of understanding the studies that provide class 1 evidence. So by that I mean these are studies that are randomized, they are controlled clinical trials. They control for the intervention of interest, and they mask the outcome, meaning that the person in the study and the raters don't even know what outcome they're trying to get. They're just measuring what really happens. And so those kinds of studies will provide evidence that is something that you can use to guide clinical interventions. And then I wanted to share a couple of interventions that I thought were interesting, and maybe your listeners would, if they have an interest, they can look this up and find out more details. So I'll just give very basic information, but give you the titles of a few interventions that were described.
Sure.
So one was the Kessler Foundation Modified Story Memory Technique that Nancy Cervalotti from the Kessler Foundation has really championed. And this includes, 10 sessions that are completely manualized, which means that you don't have to go to a particular psychologist to get this, or even a psychologist at all. You just need a professional that is willing to read this manual and try to follow the directions that are written out. And they have provided class 1 research evidence to show that this can improve memory for people with MS. Another technique is called attention process training. And the idea is to try to focus on basic sustained attention to a task and executive functioning, both of which are affected with people with MS. And in one study, they saw a significant improvement in people with MS. Another intervention is called RehaCom, R-E-H-A-COM. This is a computer-based program that was published like 15 years ago. Maybe the most creative result is that it's in 27 languages, and that you do need to do this with a therapist, a psychologist, or a counselor, but they can have control and kind of personalize the program for you. And they've found that you can focus on specific aspects of your cognition that are a problem for you, like attention or memory or executive function. So it kind of works in that adaptable way. And the last intervention is called speed of processing training in MS. So I'm not sure if you've heard of Brain HQ. It's a game, a computer game that is available to the public now.
I have heard of it.
So they have done studies in MS specifically where they've shown that this can provide improvements in processing speed and memory, and they found that not only is there an immediate effect when you do the game and immediately after, but they found that even if you've been doing it for a few weeks and you stop, there's still improvement 6 months later. So this idea that you don't have to continue doing it every day might be really appealing to us, and something to keep in mind. So I really appreciated that they went through some of these different options so that consumers kind of know what they have available to them, even if they're not able to get to a large clinical center or have access to a psychologist that has a specialty in MS.
Well, that's what I love about coming to meetings like this. You're always finding things that can actually help people improve. And sometimes when you're affected by MS, you lose sight of the fact that there are things you can do that can actually improve basic function, basic cognition. These are things that overall, they give you a better quality of life.
Right. And they're the side effects compared to a drug are just really different, right? The side effect is effort and time, but there are not the medical side effects that you often get with some of these medications.
So true. Dr. Kathy Zackowski, thanks again for stopping by. Thanks for everything you do to improve the lives of people affected by MS, and I'll see you next year.
Thank you so much. I hope you enjoy the rest of the conference.
I also had an opportunity to talk with Dr. Stephen Krieger, a neurologist at the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at Mount Sinai. In my opinion, Dr. Krieger is redefining the standard of care when it comes to treating someone living with MS. I am here at the Consortium of Multiple Sclerosis Center's annual meeting. I'm speaking with Dr. Stephen Krieger. Dr. Krieger is a professor of neurology at the Icahn School of Medicine at Mount Sinai and a neurologist at the Corinne Goldsmith Dickinson Center for MS. And this morning, he was one of 3 presenters at a presentation titled The Hidden Side of Multiple Sclerosis, Harnessing Key Pathologies to Improve Outcomes Across the MS Spectrum. Well, welcome, Dr. Krieger.
Thanks so much for having me.
It is my pleasure. And I guess we can jump right in and ask you to tell us what the hidden side of multiple sclerosis is really all about.
Sure. Well, I think you and your listeners and audience know an enormous amount about multiple sclerosis, both the well-known and the hidden. But what our program was really about today was how we're looking at the disease differently than we might have looked at it 5 or 10 years ago. How we can better understand what causes symptoms, what causes relapses, what causes progression, what progression really is, and the ways that we have been able to, with more modern science and more modern imaging and blood tests, try to better understand what's happening in an individual person with this disease. So hidden in the sense of what was not obvious to us before, and how we're looking at the disease in a new way.
I think I actually heard you say MS is dynamic, and it's dynamic in ways we didn't initially even think about.
Yeah, it's true. I think everyone living with MS knows that it can be dynamic in a frustrating way, in a difficult way. Many years ago, one of my patients said to me that perhaps the hardest thing for her about having MS was that she constantly had to create a new normal or understand what a new normal was anytime MS caused something new or took something from her, that she had to kind of up and build a new foundation for her life because it kept changing. And that feeling of being uprooted and constantly having things taken from you or potentially taken away by this disease is perhaps its most overwhelming and frustrating component. And so it can be dynamic in that it's always changing. But I think that from what I said this morning, that the disease is dynamic even in ways that we didn't always appreciate. I was thinking specifically about how we look at MS on an MRI scan. So, we perform MRIs, we look at the lesions in MS, and lesions, in a sense, are forever. They never go away. But I tend to think that lesions are static, that they don't really change. Once a lesion forms, it's there, like a scar. That's what multiple sclerosis means, multiple scars. But more modern imaging, neuroimaging with MRI, and more modern science has shown us that the lesions themselves keep changing. Some of them expand, some of them enlarge, some of them have rims of inflammation around them, even when we thought they were quiet. And so that sense that the disease hides a certain dynamism, it hides a certain types of changes that are probably really important and were hiding in plain sight before, that's the kind of thing that allows us to look in a more detailed way at the disease and can surprise us still, even here we are 30 years into being able to treat MS, but it still surprises us.
In part of the title of today's presentation mentioned this, and I also heard you mention it as you were giving your presentation, the idea of looking at MS as a spectrum.
Yes.
Can you talk about how you see that?
Sure. I think everyone with MS knows that no two people with MS are quite the same. And that makes the disease hard to treat in some ways because everyone's different. It makes the disease hard to study because everyone's different. And in science, in clinical trials, for instance, it's easiest to study something that is predictable and behaves in a singular way, because then you can know whether your intervention works. But when a disease is as heterogeneous, as variable as multiple sclerosis, and as different from one person to another, the way we've done our studies for many years is to group people together and call it things like relapsing remitting multiple sclerosis, period, or secondary progressive multiple sclerosis, period, as though those categories are able to describe individual people. And one thing that I've realized that I think so many folks with MS know is categories are not people. Everyone is quite distinct. And for some people, what makes their MS behave the way it does is relapses. They don't really have progression. They never really worsen except for those relapses. For other people with MS, they may not have relapses, but they may be constantly progressing and worsening over time. And rather than think of MS as discrete categories, I think it's more helpful to think of it as a spectrum of things that are happening. For some people, more relapses. For some people, more progression. For some people, neither, when the disease is stable, and it really can happen. And so that notion of the disease as a spectrum of mechanisms rather than as categories is where I think the field is going. It's where the National MS Society is taking it, with the perspective of looking for a more mechanistic, a more biologically meaningful explanation for the disease rather than simply as categories. And then the last thing I'll say about it, I know this is a long answer, but the last thing I'll say about it is that the disease changes over time for a particular person. And so there's a spectrum of disease over someone's life, which can't be just described in a singular term. So this has been a guiding principle for me for the last few years with my work on the topographical model of MS, which is my kind of way of looking at the disease, that concept. And in that concept, often called the leaky swimming pool model, the spectrum is a spectrum of how full is someone's tank of reserve, how much ability does their brain and nervous system have to compensate, and then how many lesions, where are the lesions, what kind of relapses has someone had, and that interplay of the tank of reserve and the lesions, I think, underscores this idea of a disease spectrum.
One of the things you talked about today, and it's also in a paper that was just recently published, is the idea of when somebody comes to the clinic, we detect only what we measure.
Yeah, yes.
Tell us what that means.
Oh, well, it's a simple sentence. We detect only what we measure, but I'm trying to capture a lot of things about the MS community in that one sentence. So for so many people, I think they know how they feel in their bodies, and they know how a disease is affecting them. The person with the disease often knows that they're worse. And I think it's not a rare experience for someone with MS to go see their neurologist. The neurologist does the neuro exam, move the eyes around, move the hands around, tap the knees, put the tuning fork on the feet. And the neurologist doesn't find anything new. And the neurologist says, looks stable to me. Or does an MRI scan, and the MRI scan shows no new lesions. Looks stable. And that doesn't necessarily reflect all the things that person is experiencing, the things that have been called invisible symptoms, the progression that has been called silent progression. And so the concept that we only measure what we look for, we only capture what we test for, means we need to look harder. We need to find ways of looking at people with more nuance, with more detail, with greater challenge, to find the things that people with the disease know that they're living with. And the phrase that I used in the paper that we published recently in a journal called Current Opinion in Neurology, this was myself and my co-authors Karen Cook and Carrie Hirsch. Karen Cook was one of my original topographical model of MS co-authors. Carrie Hirsch is at the Cleveland Clinic in Las Vegas. What we said is that progression is only silent if we're not listening carefully. And symptoms of MS are only invisible if we're not looking hard enough for them. And so the mandate is on us as the clinicians, the doctors, the care providers, the scientists, to look harder, to capture more of this, and to not be complacent, to not think that something hasn't changed just because we weren't able to measure it.
Well, I have to say, in your paper and during your presentation, you took some very complex ideas and really distilled them to a simple sentence that said so much. Certainly, we detect only what we measure as one. Yeah. EDSS 0 is not normal.
Yes.
Is another.
Yeah, so, it's a little bit of a niche title of that paper. EDSS 0 is not normal. It's not going to mean anything to folks outside of the MS community. But in the MS community, where we have used the EDSS to measure disability for 40 years in all of our trials, all of our studies, it's a provocative statement for the MS community. So the EDSS, just for anyone who's listening who doesn't know this, I think probably most of your audience does, but the EDSS is a way of grading physical dysfunction, physical limitations from multiple sclerosis. It's essentially the neurological exam, graded on a scale from 0 to 10. 10 is someone who has passed away, not necessarily from MS, but just at the end of life. 9 and 8 are people who are extremely physically limited from their disease, basically confined to a bed. 7 is someone who gets around, but using a wheelchair. 6.5 is someone who uses 2 sticks or a walker. A 6.0 is someone who uses a cane. 5, 4, 3, 2, and 1 are findings on the exam. Someone who has some weakness or some numbness or some imbalance, cognitive symptoms. And 0 is normal. 0 is no findings. So an EDSS of 0 says that the MS has caused nothing. And what we did at our center, this is work I did with Jim Zackowski, my colleague who's done a lot of work on brain reserve. We looked at people with an EDSS of 0, people with MS, with an EDSS of 0, and we did more challenging things to them. Instead of just a quick strength exam, we had them grip a dynamometer to measure real strength. Instead of just a few steps of balance walking, we had them walk on an elevated beam and try not to fall off. Nobody hurt themselves, which was good. Instead of simple coordination tasks, we did much more complex, challenging coordination tasks. Anyway, what we did is a series of more challenging tasks and found that these people with MS with an EDSS of 0, no findings on a normal exam, had deficits. It was harder for them to do those tasks, which reveals that EDSS of 0 is really not normal. Just saying that EDSS of 0 is normal is our missing something right from the beginning. And so if the EDSS of 0 is not normal, our whole system for evaluating the disease burden, evaluating what MS has done to someone, is flawed right from the beginning. And again, it gives us this mandate to look harder, because we're only gonna measure what we're assessing, and so that's my kind of call to action for people like myself in the field, which is look harder, expect more, try to see what the disease is doing beyond the simple measures like the EDSS.
Well, Dr. Stephen Krieger, thank you for everything you do to improve the lives of people living with MS and those who are affected by MS as well. And thanks so much for stopping by to talk with me this afternoon.
I really appreciate it, John. Thanks for the opportunity, and I hope that some of this resonated with the people that listen to you.
That's going to wrap up this episode of RealTalk MS. RealTalk MS is powered by the National MS Society, and you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/353. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. I hope you'll join me next week for part 2 of my coverage from the Consortium of MS Centers annual meeting, when I'll be talking with Dr. Nancy Sykott about how to get to earlier diagnosis and earlier treatment for MS and why that's so important. I'll also be talking with Dr. Brian Sandroff about the impact of exercise on cognition among people living with MS. And I'll be talking with Dr. Anthony Feinstein about his groundbreaking research into the effects of cannabis on cognition in people with MS. And if you have a minute, I hope you'll pay a visit to the Apple App Store or the Google Play Store and download the free RealTalk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of RealTalk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.